Hello, hello. Today is July the 5th, 2025, and the 4th of July weekend usually is popping. This weekend has been kind of chill, but I want to tell you about an acute kidney injury case that came in on yesterday or day before. This patient was a 68-year-old black gentleman who was at an outside hospital, and he had a creatinine of 8.6, a serum creatinine, and his glomerular filtration rate was 7. We had no background history or background labs on this patient, so we were kind of in the dark as far as his past history, other than the fact that we knew he was an alcoholic and he was hypertensive and he was somewhat non-compliant with his blood pressure medications. So the question I have for you is, how do you manage a patient like this? This type of patient will come into your office and you will have to manage, treat, disposition, triage, whatever you want to call it, patients like this, because there are some patients that just don't go to their doctor, they don't get treated, and they don't really follow up as prescribed. And so we as providers, especially primary providers, because you're on the front lines, you have to be the ones to know exactly how to quickly treat this patient and manage them and get them where they need to be. So I'm Dr. James Hall. I am a nephrologist. I've been practicing nephrology for about 20 years. I'm also a hypertensive specialist, and we're just talking about how to manage kidney disease. This is my main point on my YouTube page, is to teach people how to better manage kidney disease in the primary care setting. Check out our free webinar below. Back to our case. This patient had a blood pressure of around 230 over 120. I mean, it was significantly high. It was just high enough to where he should have been stroked out, to be honest. So the original hospital that saw him was real small, and they did not have an intensive care unit. They did not have a nephrologist or pulmonologist. So he was transferred into our hospital. And when we got him, his BUN was 82, creatinine was 8.6. And, my main focus when I'm seeing patients like this is why. What caused this patient renal function to be so low? What happened? What damaged their kidneys to make them be working at less than 10%? Incidentally, when your kidney function is below 15%, that's an indication for dialysis. Whether you're inpatient or outpatient, usually 15% is our cutoff, but I do have patients in my clinic who have a GFR, glomerular filtration rate, less than 15, and they're not on dialysis. Why not? Well, those patients are stable, their albumin is normal, their potassium is normal, their serum bicarbonate levels are normal, and they aren't uremic. So those patients are doing fine. There's no need to just rush off and stick them on dialysis if they're fine. Now, when a GFR gets below 10, I start to get a little scared. I start to get a little worried, because that's when your patients really start to have a lot more symptoms, such as itching and pruritus, sleepiness, fatigue, poor appetite. That's when I pull the trigger. I don't play around with GFRs less than 10, especially if I notice the albumin dropping and things like that. This patient who came in the hospital, GFR was around 7 milliliters per minute, and we had no idea what his baseline was. His baseline could be 50 milliliters per minute, but we don't know. So as a provider, what do? One of the big things that you should always do in men is get a renal ultrasound. The renal ultrasound can tell you so much, and I'm going to pull his renal ultrasound up and just go over it with you real quick. It can give you so much information as to what their previous renal function is before this presentation. So his ultrasound showed the right kidney was 9.3 centimeters, and the left kidney was 8.7 centimeters. So Just from the size of the kidneys, that lets me know that he has chronic kidney disease, because most men's kidneys are 10 to 12 centimeters in size. Both of his kidneys have shrunk, what we call atrophy. That's an indicator that this patient has had underlying medical renal disease or chronic kidney disease that didn't just start a week ago. The other thing we look for hydronephrosis, which can indicate a blockage, especially in men with prostate issues or people with kidney stones. There was no hydronephrosis on his ultrasound. There was no renal cyst. The urine bladder was not completely visualized, and the bladder was completely collapsed. So the bladder was not full, indicating that there was no major urine in there, indicating that there's probably not an obstruction. So these are the things that you should look for on renal ultrasound to let you know, okay, this patient has underlying chronic kidney disease because the kidneys are small. Or this patient has no blockage because they have no hydronephrosis and their bladder is decompressed. So as a provider, if you don't have good nephrology coverage in your city, in your area, you can get a renal ultrasound and be able to interpret it based on the clinical situation in your patient's presentation. Most nephrologists, all nephrologists, order renal ultrasounds, but if you think there's an obstruction, that's something that should not wait till your patient sees the nephrologist. You should go ahead and order that renal ultrasound so that we can get it back and see what's going on with our patient. Other things, the patient's sodium was a little elevated. It was like 150 at the outside hospital. Usually that indicates dehydration or intravascular volume depletion. This patient was somewhat dehydrated. So when he came in the hospital, he had a working diagnosis of acute kidney injury of unknown significance. We did not have that renal ultrasound at the outset. So we hydrated him. He was a little bit hypokalemic also. His serum bicarbonate was 24. It was normal. And when we hydrated him, his renal function came up to around 8 or 9 milliliters per minute. And he has not improved in 48 hours. So my thought process is that this patient probably has end-stage kidney disease. Given the fact that his kidneys are small, significantly smaller on ultrasound compared to a normal male's kidney, given the fact that he has severe hypertension, which hypertension is the second most common cause of kidney disease, that's why we harp on getting the blood pressure down. It is the silent killer. And based on the fact that he is non-compliant. So those things tell me this patient probably has end-stage kidney disease. We are planning to place a dialysis catheter on him in the next 24 to 48 hours and start dialysis. It is a holiday weekend, so there are some challenges there. He's totally asymptomatic, believe it or not, with a kidney function of 8 milliliters per minute. He has no major symptoms of uremia, itching, fatigue, tiredness, and that type thing. And typically what I see, if a patient has a GFR that goes from 50 to 10 in a matter of days or hours, then they can feel that. They can appreciate something's just not right. But if a patient's kidney function goes from 12 milliliters per minute to 10, they can't really feel that. Or if it goes from 20 to 19, from 19 to 18 milliliters per minute, from 18 to 16. Most patients can't fully appreciate that subtle change in renal function. That's why a lot of people come into your clinic and they say, I feel fine. I don't have any symptoms of kidney failure. I don't feel bad. And that really doesn't mean a lot other than the fact that they just can't feel it. That's why we always check labs. And that's why we always want to look at an old history, an old chart, old labs to see what the patient's old renal function was actually doing. That's the clinical management skills that I want to try to impart to our community, especially the primary care community, and physician extenders, because this is the information that will help you quickly identify if your patient has an acute kidney injury or if they have just a normal decline in their kidney function, what we call chronic kidney disease. So we plan to dialyze this guy in the next few days and set him up for outpatient dialysis. If his renal function is not improved, I was hoping that this was all acute, but after seeing his renal function, his renal ultrasound, his labs, I'm thinking it's probably going to be chronic. One other thing that I use to tell me if a patient is chronic or acute, I check serum PTH levels, parathyroid hormone. Your parathyroid hormone goes up in kidney disease because patients become vitamin D deficient with CKD. And so when you're vitamin D deficient, your calcium levels are lower, serum calcium levels are lower. Your parathyroids see that hypocalcemia and they start kicking out parathyroid hormone. So your parathyroid hormone levels go up, PTH goes up. And if a person has a high PTH level, that tells me that they probably had underlying long-standing chronic kidney disease, long-standing vitamin D deficiency as a result of that kidney disease. That's what makes their PTH levels go up. So these are some of the subtle clinical skills that we use to try to diagnose what's going on with our patients when they come in. They have absolutely no history at all. This patient was admitted to the intensive care unit. He was started on a cardiac infusion to try to get his blood pressure down. His blood pressure has come down nicely, and sometimes malignant hypertension can shut your kidneys down. I've seen this happen, and once we get the blood pressure down, patients' kidneys can kind of open up and start to put out urine and start to work. So that's another differential diagnosis in this case report. Malignant hypertension can cause severe acute kidney injury. So that's why I was not quite so quick to put him on dialysis, because sometimes severe malignant blood pressure elevations can cause your kidneys to stop working acutely. And when you improve the blood pressure, the kidneys will start back working. So I may do another video on this case just to kind of tell you how we manage acute kidney injury of unknown origin. I hope this video was helpful to you. Check out our free webinar below. It will talk about a lot of cases like this with all the clinical vignettes that help you readily manage chronic kidney disease in the primary care setting. That's what I want to do. I want to help the world, every single person out there who's managing nephrology patients, CKD, be able to quickly diagnose them, manage them, and get them to nephrologists if necessary. But even if you don't have a nephrologist, you will know exactly how to treat these patients. So we'll see you in the next video. Check out our webinar. Check out our nephrology course below. Thank you for listening. Goodbye.